Welcome back. Session 8, Project Healthspan and Federal Legislation. We're going to alter the sequence here a little bit, and that's going to work great because it is my honor to welcome Dr. Donna Shalala, also Congresswoman Donna Shalala. But first, I'm going to ask my friend and colleague, Jay Skyler, who knows Dr. Shalala going back many years, to introduce her.
Thank you, Zan. And it's a pleasure to do that. Donna Shalala was the longest serving Secretary of Health and Human Services that we've had in this country. She served throughout the entire Clinton administration. And after that, the question was, what would she do next? And what she selected to do was respond to a search committee that selected her as the president of the University of Miami, where I work and have worked for 45 years now. And Donna was president of the university for 15 years. I had the privilege of getting to know her during that time. And she was a really spectacular leader for the institution. It grew by leaps and bounds during her time as our president. And subsequently, after she stepped down from being president, served a brief period as president of the Clinton Foundation, she now is my congressperson. And I'm proud of that. I live in her district where I'm sitting right now. And we're going to work very hard to be sure she's reelected 3 weeks from now. But she's an expert on health. And I'm going to open it to Donna Shalala, Congresswoman from Florida, to give our keynote address.
Thanks very much.
Congressman Shalala, we are so honored to have you. Great to see you there in sunny Florida. I know you're busy, and we greatly appreciate your taking time to join us. It means a lot to us, and it's going to be a very valuable conversation. So there's no one on the planet who is better qualified to talk about public policy and governmental support for a major health initiative. And so I'd like to just start by getting your reaction to the underlying thrust of the Metabesity and Project Healthspan initiatives, and that is to encourage the nation to embrace the prevention of major chronic diseases and modify the aging process. So take it away.
Thank you very much. You know, obviously, we've got a huge increase in the number of people who will be over 65 over the next couple of decades. And that's also true around the world. So we need to look at this, I think, holistically. And I like the approach that all of you are using. And let me say a couple of things. First, I think COVID-19 presents a separate challenge because we are creating another generation of people with chronic diseases. Those who get serious COVID are clearly emerging, and we don't know enough about this, and we need to anticipate that in addition to the chronic diseases that we know about, COVID is going to give us another set, some of them related to the heart and the lungs, but we're not quite sure exactly where we're going to be. And this is particularly true for people who are getting older. And so I wanted to make that point because whatever our numbers are now, they're going to be much larger. And the management of chronic diseases, the identification of treatments for chronic diseases, our ability to in a very organized way to produce new breakthroughs in medicine and public health and social and economic development, which has already helped us to increase the lifespan but what are the resources and services that are going to be available in the future? But more importantly, what are the innovative ways and what are the breakthroughs? Do we need something like the Orphan Drug Act to incentivize the scientific community to try some new approaches? But it's very clear that even though some other kinds of drugs and other things, addiction has slowed down our lengthening of people's lives, there's no question that COVID has presented us with absolutely new challenges. And our job is really to anticipate the future. Not simply those of us that are in politics, but the scientists themselves need to help us structure what our challenges are going to be in the future and how we organize for that. And as I indicated, globally, we're facing a major demographic shift. And it's going to put significant strain on our economies, on our healthcare systems, and on our social structures. We can't ignore the effects of growing aging or of these chronic diseases any longer, and we're going to have to do a lot of work. We're also, some of us are waiting for the Healthy Longevity Report of the National Academy of Medicine, which is going to propose a holistic strategy. I'm not sure they're going to talk about the economic and political incentives for the scientific breakthroughs that we're going to need in the future. I'm hoping that they will be doing that. Looking at the panel, they should be doing that at the same time. But for those of us in Congress, there's deep interest in this subject, not simply to extend life, but to extend the quality of life. And there's deep concern that we don't know enough about the impact of COVID and what's going to come after COVID to create a new group of chronic diseases that we're going to have to deal with. So let me end there, and I'd be happy to answer any questions any of you may have.
Well, I love that you've hit many of the major themes of this conference. And indeed, we've talked about COVID, but you made one point that I think is particularly important that we haven't really considered, and that is, as you say, that COVID is not just something that we're hoping to prevent, but something that is causing a class of disability that we're going to have to deal with for decades to come. So it's an invaluable comment, one that I hadn't really thought about.
No, as a cabinet officer, as secretary of HHS, I always thought my job was to think ahead.
Yeah.
I had plenty of people that could handle the existing situation, but my job was to jump ahead and to try to anticipate the future.
Well, right. One particular objective of this conference is actually to come up with practical ways of moving the needle. And that's one reason we have you on, to give us advice about how we as stakeholders in this effort can approach Congress in an effective way. And so could you talk a little bit about specific advice for how you would suggest we proceed?
Well, you know, some of the approach, we will always have bipartisan support. We built it in the 90s for increasing the amount of money in NIH. Whoever is the NIH director also needs to anticipate the future for us and think about these issues that you're all thinking about. And we can't put aging in just a specific institute. It really cuts across, as Jay has taught me over the years, it cuts across all of the institutes. So making sure that we have the leadership there that's reporting to Congress. And I think the Institute of Medicine report can be very influential, though I'm not sure that they think about legislation like the Orphan Drug Act that's so creative that will incentivize the industry in particular to move ahead on some of these issues, and that will use modern technology We've seen some breakthroughs just during COVID. We use modern technology integrated there to help us really anticipate and develop a real holistic strategy for the future. But we're ready to go in Congress. I mean, there are enough committees and people that are interested enough. And everybody in Congress is aging, by the way. The leadership of Congress,
well, we've noticed.
age is over 65.
Well, I want to bring my colleagues then to extend the conversation. And by the way, we know that you may have to leave at some point, and we'll certainly understand when you do. But Adriane Berg, who is now the director of the Kitalys Institute, a organization that's been established to help move the needle. And then my colleague and dear friend, Thomas Sir, who has been very much in the thick of this effort to bring organizations together, both professional organizations and advocacy groups, to form a consortium that could be effective as a way of approaching Congress for the kinds of things you're suggesting, policy changes, even legislation. So let me turn to Thomas Sir, who might preview some of the ideas, and you even referred to one, a act or a law that would in some way incentivize the development of approaches, not just drugs, but anything that would help.
Thank you, Zan. Good afternoon, Representative Shalala. The project Healthspan is founded on the thing that disturbs me the most, I think, is that we are behind as a country, US. There are other countries around the globe that are thinking more strategically about extending Healthspan. The UK, for example, which has adopted a strategic objective to extend Healthspan by 5 years by the year 2035 while increasing equitable access. So I have a certain amount of envy. I'd love to see us as a country get into a benevolent arms race, if you will, for the longevity dividend, a topic that'll be covered in the next session. And so talking about the Orphan Drug Act as a possibility, I also want to bring Dave Fox from Hogan Lovells into the conversation, the 21st Century Cures Act, things that maybe helped to promote the advanced therapies space in the US several years ago. We'd love to see that kind of thinking brought into the steps in Project Healthspan to expand government assistance for promoting Healthspan.
By the way, Congresswoman, David Fox and I go way back to FDA days. David worked in the General Counsel's office while I was in one of the review divisions of the Center for Drugs. And so you were our ultimate boss. We didn't talk to you very often, but we admired you a lot. And again, we're glad to have Dave here, who is my go-to person when it comes to anything to do with a complicated food and drug law matter. So David joins us from Bethesda, and we're delighted that we could speak to our former boss.
Thank you, Dan. Good to see you, Secretary Shalala. And good to see you at the U. I have a daughter at the U also, so shout out to the U, Miami. Okay. And in our pre-panel discussions, one of the things that came to mind when I knew you were going to be on the panel was way back in the mid-1990s when we were working on the tobacco rule, and you and Commissioner David Kessler were instrumental in leaders. And I remember, culturally at the agency, there was a lot of resistance to the project until you and David Kessler jointly reframed the tobacco issue as a pediatric disease. And when we began thinking about it as a pediatric disease, it really changed the energy within the agency about getting behind it. And I'm interested in your thinking about, and there's going to be a lot of discussion in our conference about the idea of recognizing aging perhaps as a disease in itself, or similarly framing it in a way that makes it more amenable to the regulators as something for which therapeutics are appropriate, interventions are appropriate. And so it stuck in my mind what a sea change it made back then, and the foresight that you and Dr. Kessler had to think about it that way, as opposed to a social issue, the way tobacco use had been thought of before then. So that's another issue that we're grappling with, is how exactly do we start talking about aging in a way that makes sense to the regulators and gets the regulators motivated and interested, in addition to the incentives that we want to talk about from a legislative perspective.
That's a very interesting question. You mean arguing that we're trying to figure out how people can live forever isn't enough of an incentive for the people at the agency?
Right.
You know, one of the reasons that medicine in particular and the regulatory people have not been as deeply interested is, if you think about this, most of the great strides in longevity have been made by public health. That they, you know, it was clean water, clean air, vaccines that really extended life. It was not necessarily therapeutic interventions or even the specialties as such. That it was really some fundamental things that we did. We did building codes, but clean air and clean water and vaccines and building codes probably had more to do with extending life and taking giant leaps. What we have to do is decide that there are a set of strategies that actually will do more than incrementally extend life or extend the quality of life. I'm happen to be interested in the quality of life as people are aging. And I think, you know, that's central. So figuring out how to frame that, you're absolutely right, will be the challenge. And that's why some kind of a holistic approach, so that we put not just the legislation, but the other pieces together and make some claims. Not that we're going to do a war on cancer. I hated that term at any point, but that we're actually going to figure out how to both extend life and extend the quality of life and the economic implications of that. But you're right, we have to put some kind of a package together because everything else we're doing is more incremental, and you can't sell incrementalism.
That's so true. And you've made a fundamental point about the basics, how they really have to be considered the low-hanging fruit that should be implemented before you go for high-cost therapeutics and technology. And part of the conference, indeed, is stressing the importance of the basics like good nutrition and physical activity, addressing social loneliness. These are all part of the puzzle, and the conference is hoping to cover that waterfront as best it can in a very limited period of time.
I'm a big believer in low tech versus high tech.
Yeah,
That you start
exactly.
out figuring out.
Shalala, on that very point, I have a question about public education. I had the privilege a few years ago to be working with a different regulatory agency, Department of the Treasury, to actually get information out to the public on their own personal finances, and it did work. Now, I was wondering whether or not you can give us some guidance on how perhaps one of the regulatory agencies or Health and Human Services could educate the public about aging, because we really don't have those basics that Fleming just talked about. We think we should be thinner. We think we should exercise. It sounds right to us. We try. But really, we don't have the geroscience background, which can be translated for the public, just like financial information is now readily available to the public. And I wonder if you see a legislative role there.
Yeah, you know, public education campaigns are very tricky because we go in and out of them so fast when we need long-term strategies and a lot of discipline. So, but to be able to identify the handful of things that people can do, and surgeon generals have tried, but their voices have not been large enough. It almost has to be a government-wide commitment so that people get the information from every direction when they turn. I'm thinking of the fact that when I arrived at the department, only half the kids were getting their immunizations on time. It took the entire government to turn that around, plus state and local governments and the healthcare system, but we didn't depend just on the pediatricians. So I think you have to decide what are the 3 or 4 things that will make the biggest difference, and then literally organize the country, and that takes presidential leadership. Sure. And a clear message.
Yeah.
I mean, right now we're suffering from the lack of consistent, clear messages on COVID, but you can see the difference when you have presidential leadership that's very clear, including what the implications are. So yes, we can do it, but we can't do 4,000 things. It would have to be, we'd have to figure out what the 3 or 4 things are that would make the biggest difference.
You know, you mentioned the message to Congress of if they haven't thought about it and everybody is aging and they haven't seen the value of living forever. I think that is one of our optics problems. It's really not about living forever. It's, as you say, it's about living well for as long as you can and having as many years for contribution as you possibly can. And perhaps that's our message. People, legislators, the president can envision that kind of life for everybody. We may have a message there.
And we have an advantage, and that is immigration. Because if there's anything that ethnics understand, it's deep respect for their elders. In my community, talking about the quality of life for seniors is a campaign issue. I mean, because in the Latin communities, in my own Lebanese community, the elders are revered, and anything we can do to improve the quality of life. And therefore, you know, Congress talking about home health workers, keeping people in their own homes as long as we possibly can, the nutrition issues that are related, as well as healthcare, dealing with loneliness. And so putting all those things together, there are such advantages in large parts of our country because it will resonate with these immigrant communities that are multi-generational.
You know, it was the International Day of Older Persons, and you're absolutely right. It was led by Argentina, and it was such an incredible event. So I just hope your view will be able to support us in what we're trying to accomplish.
Congresswoman, I have a question. I'm afraid I'm drinking my own Kool-Aid, so maybe you can help us here. When we look at the issue of healthy longevity, it seems like a no-brainer, a bipartisan kind of proposition. It's a triple win, certainly for the elderly and their quality and quantity of life, their caregivers and family. For the, you know, our healthcare costs are headed off the cliff. In terms of public and private reimbursements, and something like the delay of chronic diseases by a couple years makes a huge difference in the curve, the trajectory of the costs, healthcare costs. And then there's the economic opportunity from having tens of millions of vibrant, energetic, engaged, alert seniors who are running around and buying goods and services. Are we drinking our own Kool-Aid? Why is it not something that is a top priority for every legislator, every person in the executive department, et cetera?
Some of it is because they don't think in terms of integrated policy. David, we had this conversation when we were dealing with tobacco, because someone would inevitably bring up, oh my God, we're running up Medicare costs in the future if we stop people from smoking.
Oh.
Incredible.
And, I don't want to argue the moral position, but I do want to say that all of the analysis provides an economic incentive for doing this, because if we extend life, we also reduce healthcare costs in the long run.
Well, you also mentioned the National Academy of Medicine project, and by the way, you are a member of the National Academy of Medicine, and well-deserved. Do you see other things that should be done? You mentioned some kind of robust economic case to be made. What would you see as the other legs of the stool that need to be addressed to attract broad bipartisan support?
The biggest one is to make the economic argument. We're not going to have a lot of money left at the end of COVID, and we're going to have to make strategic investments, and pointing out what the economic implications are to the extent that we can analyze the economic impact of all of this. And in the process of reviewing the tax system, which we're clearly going to do, figuring out how we can use tax incentives to do this as opposed to grants. That will result really in the economic success that we expect by doing this. So we just have to think it through. But the administration, it's hard to get people in Congress to think programmatically. They think programmatically. They think in terms of existing programs and adding on to them. And every once in a while, they're willing to do a tweak. But getting them to think about an overall strategy, I've been surprised, but I shouldn't have been surprised, because most of the big strategies that we did during the 90s came out of the executive as opposed to out of Congress. And some of it is the fragmentation of the committee system. I hope that my next committee will be Ways and Means, because it's the most powerful committee in terms of economic incentives for science and technology development. And I'd rather be on that side, and it has some regulatory roles as well. So we'll see. But there are real challenges.
Can you envision a caucus, a Healthspan or Healthy Longevity caucus?
I'm sure I'm a member of an aging caucus. I don't know whether it's, we should probably rename it and re-strategize as part of it. And that's one of the things that I'll think about next term. And by then we'll have your input as well as the Institute of Medicine.
There is a previous example
in this area and get you all to come up and tell us how we should think about this. David, what do you think about that?
Yeah, we would be delighted. I think we've started to lay the groundwork for that, and we have a nice outline of a Healthspan Promotion Act. But I think, Jay, you were going to say something, and I can step back in.
Congresswoman Shalala mentioned earlier about the need for wide-scale education to have people pay attention to this. And there is a previous example of that In 1972, the National High Blood Pressure Campaign came out in the United States, arguing that we should reduce the normal upper limit of blood pressure to 140/90. And we educated people in schools, in churches, everywhere to try to get them to control blood pressure. And we did a great job of that. And we were the only country to be doing that. The rest of the world went with the WHO recommendation of 160/95. And we were the only ones, the United States, who changed the trajectory of death from heart disease between 1972 and 1990. And so I think but that meant going into schools and churches and everywhere else and getting everybody to think about this. But it's the kind of thing we might want to use for promoting Healthspan as well.
Yep.
Yeah, I think that's a really interesting example. In that it seems to be a little bit of a lost art. So if you look back over the last decade or more of changes to the regulatory sort of scheme, a lot of the tweaks, and even go back to the Orphan Drug Act in the early 1980s, but the more recent recognition of things like breakthrough designations, which Secretary Shalala mentioned, they've had the effect of directing the industry and the regulators to looking at very narrow disease segments, small populations, orphan populations, very, very targeted therapies profoundly affecting patients, but very small numbers of patients. And we've really lost the focus, Jay, on those larger, cross-cutting issues that affect, large swaths of the population, like blood pressure, like metabolic disorder, obesity, chronic heart disease. And yeah, exactly. And so I think one of the things as we go about developing a Healthspan Act is to try to figure out how we can reorient the system around larger preventive therapy or preventive interventions. And low tech is fine, and some of this could even a lot of this can come out of the medical device field about just monitoring systems that are now available to consumers. But we really do need to figure out how do we not have our next set of incentives, again, drive the industry towards narrow, focused patient populations who can generate very large prices for reimbursement. How do we get people looking more towards those smaller, low-tech interventions that affect many, many more people in the population?
Well, the challenge is that we've never figured out the reimbursement for low tech.
Yeah.
That we haven't made it attractive enough from an economic point of view to change behavior. I mean, we ran major campaigns on AIDS. Sometimes you can attach it to something. I remember being in Australia and discovering that the way they reduced cancer in Australia is they actually required no kid could go outside without a cap. And they all kept caps in their desk. And they just weren't allowed to go out for recess without putting a hat on. And it actually had an impact in skin cancer. But it was tied directly to something the kids wanted to do.
Congresswoman, we noticed that you and Congressman Jamie Raskin, who happens to be David Fox's representative, and actually I believe, David, you know Jamie very well, but you two are partnering on a COVID-related project, and you might say a little bit about that and how it could, in some ways, relate to what we're trying to do in improving the situation with respect to declining immune function that goes along with aging.
Yeah, our proposal actually was the real strategy the federal government should have used. It identified what the federal government should do, what state governments should do, what local governments should do, and identified a strategy to put the public health people in charge and had the states coming in with their strategy having the public health people reviewing it, and then the Congress funding every piece of it. So there was an integrated execution of testing, of treatment, and of and all the other parts that public health needed to do, including contact tracing and isolation. But the federal government didn't want to take its role. And without that, you can't put the other pieces together.
Right. Do you think there is value in?
We know how to design these things. The question is, do we have the political will to do it? And can we get the attention of policymakers as well as obviously of the Congress to do this? And I think with what you're doing, we have a chance. If you look at the overall numbers, and we also have to get the UN to pay attention. I mean,
Sure.
WHO is absolutely overwhelmed at the moment, but this has to be an international effort, a global effort.
As Thomas mentioned, we are seeing movements around the world, initiatives to promote healthy longevity, to look for ways of making people more resistant to infection. All this is part of the solution to a healthier global village. And we should be reaching out to
Right.
countries beyond our borders.
There was a question in the chat about, can we dislodge the dietary guidelines from the Agriculture Department? All you need is a strong Secretary of HHS, because it turns out they have to do them with HHS. And therefore, we just regularly beat on them to do far more appropriate things that they wanted to do. But unless HHS plays, agriculture will look at the commodities.
Just one happy note, they did move that International Day of Older Persons from one about decline to the mission of longevity, healthy longevity. So I think we have a global movement coming along here, and the WHO report, which was released this month, says that. So I think we're riding at some sort of a tipping point. It's just very difficult to grasp the tail of that comet.
Thank you.
Well, Congressman Shalala, you have been very generous of your time. It's a very busy season. It's a federal holiday, not that you ever take any days off, but the time that you've been able to spend with us has been immensely valuable.
Well, I appreciate that, and I appreciate my good friend Jay Skyler for the invitation. It's very nice to see all of you. And Jay, hope to see you soon.
Indeed. And thank you very much for being with us today at Metabesity.
Thanks, everybody. I
Thank
actually
you.
learned a lot.
Thanks so much. And we will continue with our panel discussion. It was great to have an extended discussion with the Congressman. We weren't expecting that we would have so much time, but she was very gracious. A lot more to be said about what's going on, and I would turn to Thomas again to maybe talk a little bit more about the Healthspan initiative that has been going on in the past year.
I actually want to pick up on a point that was made during the past 30, 45 minutes. The Congresswoman made references to incentives like the Orphan Drug Act, and we wanted to bring in the 21st Century Cures Act. I wanted to ask David Fox to comment a little bit on the effect of the 21st Century Cures Act on the regenerative medicine space in the US. I don't know, one of the questions we face from the Hill when we go around is, what kinds of federal legislation are you looking for? Because you're not going to go to the FDA and say, make aging a disease and start intervening or pass approvals on aging drugs. It has to be something that's going to help everybody. It's going to require everyone to coordinate and cooperate. David, can you comment a little bit about what the 21st Century Cures Act did for the regenerative medicine space, because maybe it's another precedent for what we can do with the healthy longevity space.
Sure. And just for a little bit of context, one of the great things about the life sciences space is, at least from a regulatory perspective, it's user fee funded. So the industry chips in to fund the regulatory body. What that means is that every 5 years, that contribution from the industry needs to be reassessed and recalibrated. So we're guaranteed legislation every 5 years, which is terrific. The next one coming up is 2022, not too far away. So the 21st Century Cures Act was done in the run up to the last reauthorization of the user fee statute. And one of the things it did is it just coined the area of regenerative medicine to cover engineered tissue and cellular products and other what's known globally as advanced therapies, mainly in the biologic space. And what's interesting is it didn't attach any sort of incentive to developing those products, no regulatory exclusivity. It didn't have any sort of grant of special timing within the review process, but it just recognized them for, Thomas, I think what you called VIP status within the agency. So like a breakthrough, which means that the regulators have to rearrange their schedules to make sure that those products are given greater attention. When sponsors of those products need a meeting, that meeting jumps to the top of the list. And just that small sort of reallocation of regulatory resources in favor of this group of products, giving a product a chance to be recognized as a regenerative medicine, and then to get VIP status by the regulators. No change in the regulatory standard, no additional reward for getting approved, but just getting the attention of the people within the agency who can exercise the greatest amount of judgment has made all the difference in the world. So we've seen in the different ways in which you try to boost development in this industry, really two major themes. One is what I call regulatory economy. That's not shortening, but it's efficiency. A certain effortlessness within the agency and coaching for your development program. So a higher level of certainty that you're not just flailing around with your development program, that you're actually working in partnership with the regulators. Second are the incentives, prolonging your exclusive time on the market, like the Orphan Drug Act. We have a pediatric statute that does the same thing. We have something called the GAIN Act for incentivizing the development of antibiotics. So we know that the industry responds to incentives, investors respond to incentives, and the industry responds to regulatory economy and regulatory certainty. And some combination, picking the right combination here for the unique needs of the kinds of interventions we're looking at, I think is what's needed to catalyze development in this space.
I really like that term, regulatory economy. We need to emphasize it because Peter Stein is not going to welcome the imposition of another program that will put a greater burden on his folks in the Center for Drugs. So we've got to make the case for a net positive result from giving FDA encouragement to advance these therapies.
Yeah, it's tricky. There's been a sort of trend away from awarding exclusivity. There's suspicion about patent term extension and granting monopolies within the industry for obvious reasons. And so the newfangled way of creating incentives is to load up on FDA, more grants of priority review, taking more of the time of the regulators, breakthrough therapy to rearrange their schedules. But we may be maxing out on that, and I can understand the frustration implicit in Dr. Stein's statement. There's only so much, so much special treatment the agency can give to so many products before everybody is special. And we need to move on. We need to figure out something else.
Well said. It's complicated, like anything that's important. And it's going to take a while to work it out. But I want to thank everyone on this panel, and particularly Jay Skyler, for being able to help Dr. Shalala to join us here. We have greatly benefited from that participation. Jay, we thank you for having a long relationship with Congressman Shalala. So thank you all. I believe we are at the end of our session.
So thanks very much.